There we go. About that. Start over. So, Chapter 21 deals with changes in hematologic function. And this is one of the reasons that we do a CBC and look at the percentages of formed elements in order to look at underlying disease or disease that simply pertains to blood production itself. Okay. Anemia is simply a reduction in your crit. Okay. It could be the result of impaired erythrocyte production, blood loss, increased erythrocyte destruction, or any combination of those. Okay. So, um, classifications, um, there are classifications according to cause and classifications according to size and shape. Okay. Morphology is classification by size, identified by the terms that end in cytic, such as macrocytic, which are large cells, microcytic, which are small cells, normocytic, which have normal size. Hemoglobin content are identified by terms that end in chromic, such as normochromic, normal hemoglobin content, and hypochromic, less than normal hemoglobin content. Okay. Anisocytosis are red cells present in various sizes. Okay. And poikilocytosis are red cells present in various shapes. Anemia is a physiologic manifestation of reduced crit and thus reduced oxygen carrying capacity. Symptoms are based on severity and the ability of the body to compensate. Classic symptoms include fatigue, weakness, dyspnea, and pallor. Dyspnea is labored breathing. Okay, pallor is just pale skin. Macrocytic normochromic anemias, also called megaloblastic, are characterized by large stem cells because of defective DNA synthesis caused by deficiencies in B12 or folate, either ingestion or absorption. Okay, these are important for DNA production, and so if you can't make the hematopoietic stem cell, all right, then you can't make the erythrocyte. Even though there is no DNA in the erythrocyte, there's DNA in the precursor. RNA processes occur at a normal rate. In pernicious anemia, we have a lack of intrinsic factor from the gastric parietal cells, which is needed to absorb B12 across the lining of the stomach. Okay. This results in B12 deficiency. Early symptoms when hemoglobin is between 7 to 8 grams per deciliter are weakness, fatigue, paresthesias, difficulty walking, loss of appetite, abdominal pain, weight loss, sore tongue. Neurologic manifestations are also present, such as peripheral neuropathy, which can cause numbness or paresthesias, such as pins and needle feeling in the fingers and the toes, loss of vibration sense, or loss of proprioception. Okay. Treatment, parenteral or high oral doses of B12, and this is a lifelong thing. This isn't something that we can cure, but that we can treat. Okay. Folate deficiency, the upper small intestine, the duodenum, and the jejunum are where most of that gets picked up. It's not dependent on any other factor. Similar symptoms to pernicious anemia, except there's no neurological manifestations. Treatment requires daily oral administration of folate. Okay, so basically, it's either a problem with you picking up the folate or ingesting the folate. Okay, these are all B complex vitamins. They're water soluble, so they should be carried in the case of B12 across the lining of the stomach directly into capillaries, and then from there straight to the liver. In the case of folate, in the duodenum or the jejunum, and then the same route to the liver. Okay. Microcytic hypochromic anemias, red cells that are abnormally small and have reduced amounts of hemoglobin, can be related to disorders of iron metabolism, disorders of porphyrin and heme synthesis. Porphyrin is like the starting point for producing heme. And of course, the heme is what binds to the iron, which binds to the oxygen. And that whole cofactor and coenzyme is held in the cleft of the globin chains, the beta and the alpha globin chains. It can also be disorders of globin synthesis. Okay. Iron deficiency is the most common type of anemia worldwide. Nutritional iron deficiency is one cause, or it could be blood loss. Okay. So this could either be internal or external hemorrhage. Okay. Metabolic or functional deficiencies are going to result. Okay. Manifestations: when hemoglobin goes to 7 or 8 grams per deciliter, fatigue, weakness, shortness of breath, pale earlobes, palms, and conjunctiva. We see a progression of iron deficiency causes: brittle, thin, coarsely ridged, and spoon-shaped nails. That's a condition called koilonchia. A red, sore, and painful tongue, dry, sore corners of the mouth. That's known as angular stomatitis. Sideroblastic anemia is a group of disorders characterized by anemia of varying severity. The presence of ring sideroblasts in the bone marrow is diagnostic. These are erythroblasts that contain iron-laden mitochondria arranged in a circular pattern around 1/3 or more of the nucleus. Okay. It's a rare blood disorder, okay, that occurs when the bone marrow produces ringed sideroblasts instead of healthy red blood cells. Ring sideroblasts are erythroid precursors that contain deposits of non-heme iron in mitochondria, and the iron-formed ring covers at least 1/3 of the nucleus. Sideroblastic anemia can cause microcytic and macrocytic anemias, depending on the mutation that caused it. Okay, so there are acquired sideroblastics, reversibles, hereditary. The leading cause is myelodysplastic syndrome, where we see common anemia signs and symptoms, hemochromatosis, myelodysplastic anemia versus sideroblastic anemia syndrome in idiopathic anemia analysis is one of the challenges that we face. Hemochromatosis is just too much iron in the blood. Okay. And believe it or not, the fix for that is to remove the iron, which is to bleed you. Okay. Normocytic, normochromic anemias are characterized by RBCs that are normal in size and hemoglobin, but low in number. They can be aplastic. You can have post-hemorrhagic, okay, acquired hemolytic, hereditary hemolytic, and anemia of chronic inflammation. Okay. So post-hemorrhagic means because of a bleed. Acquired hemolytic means that there's some sort of an infection that's blowing up your RBCs. Hereditary hemolytic is you've inherited something that produces a defective protein or a defective process in RBC production. And then anemia of chronic inflammation, okay, where again, if you have system-wide anemia, system-wide inflammation, you're going to see a reduction in blood pressure, and that can lead to anemic conditions in in all the tissues of the body because of the enlargement of the container in which the blood flows. Okay. Polycythemia is too many red blood cells. Relative polycythemia can be from dehydration or living at high altitudes. Okay. Where it's called secondary polycythemia, whereas primary polycythemia is one of these conditions in which we have an abnormality in the marrow. Okay. The stem cells are not performing as they should. Okay. An example is polycythemia vera, which we'll hear about in a second. It's a result of JAK2 mutation. Secondary polycythemia, as we've discussed, is a normal response to low oxygen levels or an inappropriate response to erythropoietin secreting tumors. Okay, so you would find a lot of those, for instance, in the kidney. So let's look at polycythemia vera.
Dr. Ruben Mesa, and I'm a professor of medicine at Mayo Clinic in Arizona. And I'm going to speak with you today about polycythemia vera. What is polycythemia vera? How are you diagnosed with this condition? What do we understand about it? How do we treat it? And what are some of the future opportunities for hopefully better therapies for polycythemia vera? But first, what is polycythemia vera? This is a disease that, in the most simplest terms, means that your body is making too many red blood cells. We know now that this disease is one of a family of diseases that we call the myeloproliferative disorders or the myeloproliferative neoplasms. This is a family of diseases in which the bone marrow is afflicted by a type of chronic leukemia that causes your bone marrow to make more cells than it should. In your circumstance, that's probably too many red blood cells, but sometimes can also involve having too many white blood cells or too many platelets. You were found to have this condition either now or in the past because one, someone did a blood count on you at the time of a general physical and found that your blood counts were elevated. Two, you might have gone in because you weren't feeling well. Patients with polycythemia vera might have been found out because they had had a blood clot or had an episode with bleeding. They might have been feeling more tired. They might have felt significant itching after bathing. They might have had itchiness in the skin or a rash. You might have had other symptoms even different than these that I described. Now, why does a patient develop polycythemia vera? At this point, we don't fully know the reason, but we know much more now than we have in the past. In 2005, it was found that one of your genes probably plays a role in the development of this disease. Not a change in the genes that you were born with, but one that you developed as an adult. That change in the genes is a mutation in a protein that we call the JAK2 mutation. The JAK2 is one of a series of on-off switches in our cells that control when our cells grow and divide. And you can think that in polycythemia vera, this on-off switch is stuck in the on position, and it's causing your cells to continue to grow, whether that be your red blood cells or the other cells. We know that there are probably more reasons, even than the JAK2, as to why patients develop this condition. 95% of patients with polycythemia vera have this specific mutation, and others have different mutations that we believe affect the cells in a similar way. How does your doctor diagnose this? Well, in addition to the blood test and potentially blood tests that tell them whether you have this JAK2 mutation, they will likely do a bone marrow biopsy. This is a condition of the bone marrow, and looking inside of the bone marrow tells us whether the condition truly exists there and also the stage of the disease. Polycythemia vera is a disease that can affect you in a variety of ways. As I mentioned, it can give you a variety of symptoms. It can also, over time, give you risk of blood clots or bleeding, and sometimes even both. Over the long term, this disease can have risk of progressing. It won't necessarily progress, but on average, after individuals have had this disease for at least 10 years, there is a risk that the disease can progress one of a couple different ways. One is to a condition called myelofibrosis, which means scarring in the bone marrow, where your bone marrow starts to become tired and starts to have a decrease in the blood counts, starts to develop scarring in the bone marrow, enlargement of the spleen, and other complications. I would refer you to our parallel video on myelofibrosis. Secondly, there is a risk that the disease can change to a process that we call acute leukemia, which is quite serious. Now, how do we treat polycythemia vera? Well, when we treat polycythemia vera, we have to think both about the short term and the long term. In the short term, we know that we have therapies that can help to decrease your risk of blood clots or bleeding. In the long term, unfortunately, we don't have any therapies that we know for certain will help to decrease the risk of the disease changing to myelofibrosis or to acute leukemia. Now, in the short term, how do we treat polycythemia vera? Well, clearly, I refer you to your doctor in terms of coming up with a plan that is most appropriate for you. But in general, we know that one, a low-dose aspirin in patients who are not allergic to aspirin is probably beneficial for most patients to decrease their risk of blood clots. Secondly, we know that lowering your red blood cell count through giving blood, otherwise known as phlebotomy, to keep your hematocrit at an acceptable range. The hematocrit is a percentage of your blood that is made up by the red blood cells themselves. So the goal percentage of that would be 45% for men and potentially 42% for women. Patients will donate blood very much like you would for donating blood at a blood drive. However, blood banks at this point in time are not allowed to use this blood for other patients. But this is another way that the disease is controlled. Finally, in a select group of patients, we will also use medicines to lower your blood counts into the normal range. Who are these patients? Those who we think are at the highest risk of blood clots or bleeding with PV. One, those individuals who are over the age of 60. Two, those individuals who previously had blood clots or bleeding. Three, individuals who are at higher risk of having heart disease or have markedly elevated platelets, perhaps over 1.5 million per cubic centimeter. There's other avenues of investigation now trying to determine who really is at highest risk of blood clots and PV so that therapy can be best tailored. When we do need to lower the blood counts with PV, we have three main drugs which are available to us. The first is hydroxyurea, which can lower the red cells, the white cells, and the platelets. The second is anagrelide, which can lower the platelets. Amongst these two, hydroxyurea probably is the standard of care. A third drug, which recent trials has shown as promising but needs further validation, is that of interferon, or even long-acting forms of interferon called pegylated interferon 2 alpha. This drug can help to lower the counts, but recent studies suggest that this drug might also lower the levels of this abnormal JAK2 protein in your blood. Whether or not this truly means that it will change the disease is something these trials will need to demonstrate. So how is the therapy of PV going to change in the future? Well, one, there are many drugs, perhaps as many as 12, that are currently in development or clinical trials for the therapy of PV. One, there's a class of drugs which are known as JAK2 inhibitors that are trying to block this on-off switch that's stuck in the on position. Some of these trials are available here at Mayo Clinic in Arizona or other centers around the United States, Europe, or elsewhere. Secondly, there are large clinical trials that are going to begin enrolling for the use of pegylated interferon 2 alpha in patients with high-risk PVERA. These are going to be offered through the Myeloproliferative Disorders Research Consortium. This NCI-sponsored collaborative group will have this trial open in many centers around the world, including here at Mayo Clinic in Arizona. The future, I think, is very bright for patients with myeloproliferative disorders and polycythemia vera especially. We know much more about this disease than we did even 5 years ago. There's many avenues of investigation right now. Many new drugs are in development, and hopefully many ways that will not only help you feel better with the disease, help to decrease your short-term risk with the disease, but hopefully will make this a much more manageable disease for the long term. I wish you a good day.
Okay. Let's jump over. Perfect. There we go.
Hereditary hemochromatosis. And I think we talked about the fact that this is one of those oddball diseases where we actually deal with it by bleeding you, right? By removing the excess iron so it doesn't build up to toxic levels. People with these conditions, they actually set off metal detectors in airports if they don't properly treat it. They get so much iron in their body. Alterations of leukocyte function. There's quantitative disorders, increases or decreases in cell number, okay, bone marrow disorders or premature destruction of cells and response to an infectious microbe getting into the marrow as well. All right. Leukocytosis, anytime you see cytosis, that means there's more than the average number of those cells in your system, right? It's a normal response when you have an infection. You want more white blood cells. It's abnormal if you don't have an infection, and can be an indication of something like leukemia. Okay? Leukopenia, penia means fewer than, right? Isn't normal and it isn't beneficial. A low white count predisposes the patient to infection. So an example of a condition that could produce leukopenia is AIDS. Okay? The helper T cell population is compromised by the HIV, right? And it takes it off task as a helper T cell, but it also turns it into a suicide pill because it expresses fast ligand. And anytime fast ligand and engages fast receptor, then what happens is that cell dies. Okay. And so that would result in leukopenia. Okay. Granulocytosis is a condition that occurs when there are too many granulocytes, which are part of our adaptive immunity, right? The neutrophils, the eosinophils, the basophils. They help the immune system fight off foreign invaders such as bacteria, viruses, fungi, parasites, and they can be caused by a lot of different conditions, including infection, autoimmunity, bone marrow disorder, and blood cell cancer. Okay. Neutrophilia is the first stage of an infection or inflammation. If needed for neutrophils increase beyond the supply, immature neutrophils get released into the blood. This premature release is detected in the manual white differential and is termed a shift to the left. When the population returns to normal, is termed a shift to the right. Okay. Neutropenia is just a reduction in the circulating neutrophils and can be caused by prolonged severe infection, decreased production, reduced survival, abnormal neutrophil distribution, and sequestration. So, severe infection, you got to remember that the neutrophils generally are the first on the scene when there is an infection to deal with the bacteria, right? So if you got like a chronic or a prolonged acute, then you're going to see a jacked neutrophil count. And what will happen as a result is that the neutrophils will do battle with the pathogen and their numbers will go down because remember they're a primary component of pus. Okay, decreased production. There could be something wrong with the marrow. Okay, and it could be inherited or it could be acquired, such as a viral infection or a cancer. Okay, reduced survival. Right, the neutrophil is defective for some reason. Right, and then abnormal neutrophil distribution and sequestration. Right. Agranulocytosis can be the result of interference with hematopoiesis, immune mechanisms, the results of chemo and radiation therapy, and ionizing radiation. Okay. The idea with chemo and radiation is to kill rapidly developing cells, and the hope is that includes your cancer cells, right? But what can happen as a result of chemo and radiation is that you could compromise rapidly dividing tissue that's to your benefit. So this is why people on chemo and radiation lose their hair and lose a lot of their skin, and their crick goes down, and the lining of their gut sloughs off, and they get very, very sick before they get better, if they do get better, right? And sometimes radiation chemo don't work, okay, especially in cancers that are slow growing, because they're radiation and chemo are primarily designed to take out tissues and cells that are constantly in synthesis, because that's when they acquire the most damage from the radiation and the chemotherapeutics. Eosinophilia is an increase in circulating eosinophils. Hypersensitivity reactions trigger the release of eosinophilic chemotactic factors of anaphylaxis from mast cells. We see an increase in allergic disorders, and that can be a cause. Remember that eosinophils, one of their job is to eat antigen antibody complexes. Okay. And then it can be increased in parasitic invasion because the eosinophil's job is to kill parasites like protozoa and helminths. Eosinopenia is a decrease in the circulating numbers of eosinophils, and it can be caused by migration of cells to inflammatory sites. Okay. Other causes include surgery, shock, trauma, burns, and mental distress. Note that all of these induce stress. Okay. And one of the things that happens with stress is the production of cortisol, and that is something that suppresses inflammation. And if we suppress inflammation, we can drop eosinophil counts. Basophils, remember, are the initiators of inflammation because they release histamine and heparin and cytokines, and that is going to bring on all of the processes that we associate with inflammation. All right. In basophilia, we have an increase in basophils that circulate. This can be in response to inflammation and hypersensitivity, right? And is seen also in myeloproliferative disorders, bone marrow cancers. Okay. Basopenia is a drop in circulating basophils that occurs in acute infections, in hyperthyroidism, and long-term steroid therapy. Now, why does long-term steroid therapy do this? When we're talking steroids here, we're usually talking corticosteroids, and we're talking in particular glucocorticoids. And cortisol or cortisone are known to suppress inflammation. Okay. Monocytopenia, all right, is a condition where the number of monocytes in the blood is lower than normal. Monocytes are the largest type of leukocyte, and in healthy adults, the reference interval for them in the peripheral blood is between 0.2 to 1, 1 to the 10th per liter. Okay. Monocytopenia is diagnosed by a complete blood count, a CBC, along with a differential, and is defined as a reduction in blood monocyte count to 500 millicentiliters times, which is works out to 0.5 times 10 per liter of blood. Okay, so you're dropping below a reference value. Cytosis has a poor correlation with disease. It usually occurs with neutropenia in the later stages of infections, and the monocytes are needed to phagocytize organisms and debris, because remember that they develop into macrophages. Okay. Lymphocytosis, an increase in the number of lymphocytes in the blood. This can happen in acute viral infections, such as with Epstein-Barr. Lymphocytopenia, a drop in the number of circulating lymphocytes in the blood. This could be the result of acquired or inherited immune deficiency, drug destruction, viral destruction, radiation. Okay. A perfect example would be AIDS. All right. Infectious mono is an acute self-limiting infection of Epstein-Barr. It's transmitted by saliva through personal contact. B cells have an Epstein-Barr receptor. Other viral agents that resemble infectious mono include cytomegalovirus, hepatitis, flu, and HIV. Okay. The symptoms are fever, sore throat, swollen cervical lymph nodes, increased lymphocyte count, atypical lymphocytes. Complications include splenic rupture, which can cause death, and that's usually preceded by splenomegaly. Over 50% lymphocytes and at least 10% atypical lymphocytes is diagnostic. Monospot qualitative tests for heterophilic antibodies is one of the cardinal signs of infectious mono. And the treatment is symptomatic because the virus can remain latent in the body indefinitely. Right? That's one of its strategies for avoiding destruction, is to integrate itself into host DNA and remain resident there for decades. Okay, it's the same strategy used by the herpes class of viruses, which are DNA viruses that can integrate. Okay. Next thing we want to look at is leukemia.
That up.
Leukemia is a cancer that usually affects the white blood cells. White blood cells develop from stem cells in the bone marrow. Leukemia results when something goes wrong with the process of maturation from stem cell to white blood cell. Usually, there is a rearrangement of pieces of chromosomes that disturb the normal control of cell division. The affected cells multiply without restraint, becoming cancerous and ultimately occupying the bone marrow, replacing the cells that produce normal blood cells. These cancer cells may also invade other organs, including the liver, spleen, lymph nodes, kidneys, and brain. There are 4 major types of leukemia. Acute lymphocytic leukemia is a life-threatening disease in which the cells that normally develop into lymphocytes become cancerous and rapidly replace normal cells in the bone marrow. It most often affects children between the ages of 3 and 5, but can also affect adolescents and adults. Acute myeloid leukemia is a life-threatening disease in which myelocytes become cancerous and rapidly replace normal cells in the bone marrow. Exposure to large doses of radiation and use of some cancer chemotherapy drugs increase the likelihood of developing acute myeloid leukemia. Chronic lymphocytic leukemia is characterized by a large number of cancerous mature lymphocytes and enlarged lymph nodes. Chronic myelocytic leukemia is a disease in which a cell in the bone marrow becomes cancerous and produces a large number of abnormal granulocytes, a type of white blood cell. This disease may affect people of any age.
Yes, yeah, and I can feel it. I can feel the stress. It's the leg. And the right is going up. We see it from the corner of my
So
eye.
what we're talking about, white blood cell cancer, right? That's going to produce large numbers of hypofunctioning white blood cells, right? And that doesn't really do us any good because it essentially interferes with the ability of your functional white blood cells to do their job. Okay. Signs and symptoms: fatigue, bleeding, which include petechia and ecchomyosis. Petechia, remember, are ruptured capillaries. You can see them in the whites of the eyes and under the skin, okay, and under the nails. Fever, weight loss, bone pain, high uric acid levels, liver, spleen, and lymph node enlargement, infections, neurologic manifestations. The clinical terms for enlarged liver, that's hepatomegaly, okay, and splenomegaly for the spleen, okay. Acute leukemias, like the name implies, come on quickly, right? Acute lymphocytic leukemia, too many lymphoblasts, occurs often in children. Acute myelogenous leukemia, too many myeloblasts, it's a common adult leukemia, and is manifested by bone marrow depression. Signs and symptoms include fever, anorexia, and neurological problems. How do we deal with this? There's drugs out there that can be used, okay, that are effective against certain leukemias. The last ditch effort to treat leukemia is bone marrow replacement. So what we do whole body radiation. We kill all your bone marrow, your red marrow, and your axial skeleton, and in your proximal femur and your humerus, and then we repopulate it with compatible donor marrow. And normally that'll fix the problem if the donor marrow takes. Okay. The reason this is dangerous is because if this fails, you're going to die, all right? Because you won't have a source of blood. So we try everything before we go to bone marrow replacement. Chronic leukemias include chronic myelogenous leukemia with too many blood cells made in the marrow, chronic lymphocytic leukemia, too many immature lymphocytes, the most common adult leukemia. It's a slow progression and is characterized by lymphadenopathy. You can see it here, right? Enlarged lymph nodes, they get palpable and tender, right? Local lymphadenopathy is drainage of an inflammatory lesion located near the enlarged node. General lymphadenopathy occurs in the presence of malignant or non-malignant disease. So, what you're talking about here is that the nodes that are dealing with the drainage, all right, are going to be the ones that are working the hardest and the ones that they swell up and hurt. Okay. So this is why, for instance, if you have, say, an abscessed tooth, you may get an enlarged lymph node in your neck. Okay. Or if you have a lung infection, you may get enlarged lymph nodes in the axillary region, in the armpit. Okay. What you're seeing here is just generalized lymphadenopathy in the panel to the right. Okay. Let's take a look at lymphoma.
There it is.
About what causes Hodgkin lymphoma. In some cases, the virus that causes glandular fever, the Epstein-Barr virus, is found in tumor tissue. This virus could be involved in the disease process in some way, but most people who have the Epstein-Barr virus don't go on to develop Hodgkin lymphoma. So although there's some connection, it isn't clearly identifiable what that connection is. A lot more work needs to be done to understand the causes of Hodgkin lymphoma. It's important to stress that Hodgkin lymphoma is not an infectious disease. You can't catch it from somebody else. And when you have Hodgkin lymphoma, you can't pass it on to anyone else either. Like all cancers, it's not contagious. Many people with Hodgkin lymphoma go to see their doctor concerned by the appearance of painless lumps in their neck or under their arms. Other people with this disease feel quite well, but a wide range of other symptoms can occur, including fevers, night sweats, itching, weight loss, pain after swallowing alcohol, and tiredness. Of course, these symptoms can also occur with many other conditions. In Hodgkin lymphoma, some or all of these symptoms can occur without any obvious lymph node enlargement, and under these circumstances, diagnosis can be very difficult. A definite diagnosis of Hodgkin lymphoma is made following a test called a biopsy. This means taking a specimen from the lump or sometimes taking out a whole lymph node and looking at it under a microscope. This is done by a pathologist. Sometimes, a group of expert pathologists will look at the sample to help decide what type of lymphoma it is. The exact type of lymphoma is very important in planning the best treatment. In Hodgkin lymphoma, the cancer cells are called Reed-Sternberg cells and have a characteristic appearance under the microscope. However, not all Hodgkin lymphoma biopsies look the same, and several types are recognized. Indeed, it is not always possible to say whether a lymphoma is Hodgkin lymphoma or non-Hodgkin's lymphoma. There is a grey zone where a clear-cut diagnosis is very difficult.
When I was diagnosed with Hodgkin's lymphoma, it was back in 2002. If I look back at the history of how I actually found out that I was diagnosed, it was a case of, if you go back even as far as sort of December 2001, I felt myself getting very tired very quickly, not being able to do what I could do. I used to be quite fit, used to work for a fitness company, do some personal training, and my role within the company was quite demanding because I was in a quite high-pitched sales role. And I just found an 8-hour day at work suddenly became a 9-hour day, and then suddenly became a 10-hour day. And it just took longer and longer to do the things I'd normally do. It came to about February. I thought, actually, I need to go and get myself checked out. Went to see sort of a GP, and they said, done normal checks and said it might be something like glandular fever. So I've gone through to see them. They've given me some antibiotics. Come back in 4 weeks' time, sort of thing. Done the antibiotics, went back in 4 weeks' time, and nothing had changed. Still feeling the same. Then it was a case of, okay, I think alarm bells are starting to ring. So I was then referred to the hospital. It was a case of going through to see the specialists there, which they undertook some tests, some blood tests. They decided that they actually wanted to have a look at the lump which was on my neck. They done a biopsy. From that biopsy, there was the results from that, and obviously further blood tests, scans, chest x-rays, of which it was then diagnosed that yes, this is Hodgkin's lymphoma. I was first diagnosed with Hodgkin lymphoma at Wigan Infirmary in 1999. I'd gone to the doctors with a niggling back, just a little niggling pain in my back, and I felt very tired, and they told me I was very anemic. So they were doing tests on me in hospital, and then after about 4 days, they sent me for a routine chest x-ray, and then that's when they found the main mass in my chest. And they said pretty quickly that they thought it was Hodgkin lymphoma, but I'd need further tests. I needed a scan, a full body scan, and then they also did a biopsy in my neck.
Staging means finding out which areas of the body are involved in the disease. Staging involves a very careful clinical examination and a range of blood tests, x-rays and scans. A bone marrow test is also sometimes needed. 4 stages of Hodgkin lymphoma are recognized. Stage 1, where the disease is limited to one group of lymph nodes. Stage 2, where disease is limited to 2 or more groups of lymph nodes on the same side of the diaphragm, that is, in the upper or lower body, but not both. Stage 3 involves lymph nodes on both sides of the diaphragm. And in stage 4, the disease has spread out of the lymphatic system. Each stage is also given the suffix A or B, where B indicates the presence of significant fevers, night sweats, or weight loss, and A denotes the absence of these symptoms.
So you can see here some of the classic signs and symptoms: cervical lymph node enlargement, and you can see rotations in the other insert where there are common sites in red for Hodgkin's lymphoma to set up. Okay. Notice that the lymph nodes are primarily in the cervical, the axillary, and the inguinal region, and quite a few also in the chest and the abdomen. And that's because those are all sites that have ports of entry, or sites that are near organ systems that have ports of entry. Right? Let's look at non-Hodgkin.
Yep.
The lymphatic system is part of the body's immune system, which is responsible for keeping the body free of disease. The lymph nodes throughout the body are connected by a network of lymph vessels. Lymph is a fluid found within the lymphatic system that contains lymphocytes, infection-fighting white blood cells. In the nodes, bacteria and other dangerous substances are filtered from lymph before fluids are returned to the bloodstream. 2 types of lymphocytes are B cells and T cells. B cells help the immune system by producing antibodies to eliminate infection. T cells are important in regulating the immune system and in fighting infections. Non-Hodgkin's lymphoma is a cancer that develops in the lymphocytes. The primary types of non-Hodgkin's lymphoma are classified according to the lymphocyte that is affected: B-cell lymphoma, which is most common, and T-cell lymphoma. Cancer of the lymphocytes interferes with the normal immune process, leaving the body unable to fight infections and allowing bacteria, viruses, and other disease-causing agents to overwhelm the body. Simple infectious agents encountered on an everyday basis that normally would not even be noticed are now debilitating and, in some cases, life-threatening. Because the lymphocytes circulate throughout the lymph system, the cancer can spread to other parts of the body, resulting in other organ function failure. Symptoms of non-Hodgkin's lymphoma include swollen lymph nodes, fever, night sweats, chills, fatigue, unexplained weight loss, and facial swelling. Non-Hodgkin's lymphomas are described as either being indolent, slow growing with few symptoms, or as aggressive, growing and spreading quickly with severe symptoms. Treatment depends on the stage and type of lymphoma. Standard therapy includes radiation and chemotherapy. Experimental therapies include hormonal therapy and high-dose chemotherapy with stem cell transplant. Most patients with non-Hodgkin's lymphoma can benefit from some type of treatment. Complete cure is possible for many patients. For others, treatment can provide relief of symptoms and extend life expectancy.
Burkitt lymphoma is a rare, aggressive type of non-Hodgkin lymphoma that hits B lymphocytes in the lymphatic system. It's named after Dennis Parsons Burkitt, first described the disease in 1958 in equatorial Africa. Burkitt lymphoma is fast-growing and usually affects children, with less frequent occurrence in younger adults. It's relatively rare in Western countries, but it's very common in Central Africa. Okay? Burkitt lymphoma are fast-growing tumors. They're often found in the jaw and the facial bones. All endemic Burkitt lymphomas are latently infected with Epstein-Barr. Lymphoblastic lymphoma is a clone of immature T cells that become malignant in the thymus, a painless lymphadenopathy of the neck, and possibly in the chest. So we call that a mediastinal mass. Remember, the mediastinum is the cavity between the pleural cavities, which contains the pericardium. Next, let's look at multiple myeloma.
Phil Fonseca, a hematologist at the Mayo Clinic in Arizona. I'm here to talk to you today about multiple myeloma. Multiple myeloma is a cancer that arises from the bone marrow, and it's a cancer that arises from the malignant transformation of cells that are called the plasma cells. You will see people refer interchangeably to plasma cells as the myeloma cells, but under normal circumstances, plasma cells would be cells that help us fight off infection. These are cells that produce antibodies. These antibodies chemically are proteins, and therefore you will see the terms being used interchangeably. And we will talk about proteins, we'll talk about immunoglobulins, but we're all talking about the same thing. This is a substance that is produced by the cells. Myeloma, it's not that uncommon. It's 3 times as common as leukemia. And there's nearly 20,000 people diagnosed with myeloma every year in the United States. Myeloma is a condition that primarily starts from the bone marrow, and we don't see a lot of cells in the circulation like you might see in leukemia. So the blood counts are, for the most part, normal, with the exception that they will show anemia. And the reason you have anemia, and that's a low red cell count or a low hemoglobin, is because the myeloma cells living inside the bones and in the bone marrow will take up the normal space that is used for the production of red cells, and that's why one of the symptoms that patients will have is anemia. Other features of myeloma include damage and erosion into the bones, what we call myeloma bone disease. Patients will sometimes have what we call lytic lesions or punched out lesions, and that is loss of bone structure as a consequence of the myeloma growth. Sometimes there's so much erosion, and as you know, the bones contain a lot of calcium, that a patient will have very high calcium levels, what we call hypercalcemia. Lastly, the proteins, the small fragment of the proteins can be filtered down through the kidneys, and occasionally this will be very toxic to the kidney. So a subset of myeloma patients will present with either renal insufficiency or frank renal failure. So those 4 things define the complications of what we call myeloma, and that is often referred to by the acronym of CRAB. C for calcium, R for renal abnormalities, A for anemia, and B for bone disease. While myeloma remains, for the most part, an incurable disease,
our ability to treat the disease is much better than what it was 5 and 10 years ago. For many patients, myeloma has become a chronic condition, and the number of therapies that are available are sometimes 5, 6, or even 7 lines of therapy for patients diagnosed with this condition. The treatment of myeloma has classically incorporated the use of high-dose chemotherapy with stem cell support, what we call also bone marrow transplant. For the most part, this is transplant done with your own bone marrow, self-transplant, or what is referred to as autologous transplant. But we also are introducing more and more some of the novel agents that are available for the treatment of this disease. There's 2 broad group of agents that we're using for the treatment of myeloma. Number 1 are called proteasome inhibitors. I know that's a mouthful. The prototype for this is bortezomib, also known as Velcade. This is an injectable medication, and it's something that has been approved because of its ability to control the disease. The other group of agents includes drugs such as thalidomide, lenalidomide, and now most recently pomalidomide. These are given in the pill form, and this is another way in which myeloma can be treated. How to select the agents, when to introduce them, when to combine them, it is all part of a complex decision process that is best made with your provider at the time of the consultation. We believe it's crucial to be very engaged as a patient, to gather as much information as you can, and to talk to your physician so that you can decide on the best long-term plan for the management of multiple myeloma. Lastly, I'd like to make a brief mention of the use of prognostic markers and genetic tools for this planning for the myeloma therapy. As you will hear, both in the literature, through some of the patient support groups and the communications that are available for patients, that more and more we're moving into this area of personalized medicine for the disease, for multiple myeloma. We will oftentimes require that we do testing for genetic factors, and we bring that information forward as we select what therapies and at what time to use them for a given patient with myeloma. Thank you very much.
Cancer that occurs when the plasma cells, which are a type of white blood cell, grow too much and crowd out other cells in the bone marrow. This causes the abnormal production of an antibody called M protein, right? What you're looking at on the right is a rentnogram of the femur showing extensive bone destruction caused by the tumor. Note the absence of reactive bone formation. In panel B, gross specimen from the same individual, myeloblastomas, myelomatous secretions appear in dark granular sections. Okay, so these malignant plasma cells infiltrate the marrow, aggregate into tumor masses. Okay, so they make that diagnostic antibody. Okay, and other markers include Bence-Jones protein. We see hypercalcemia, renal failure, and we see bone lesions as well. Alterations of splenic function include splenomegaly, that's enlarged spleen, hypersplenism, congestive splenomegaly, and infiltrative splenomegaly. Okay? Congestive splenomegaly means that the blood flow is blocked somehow, okay, through the spleen, whose job it is normally to recycle worn-out red blood cells and also remove pathogens from the blood. Infiltrative splenomegaly means that we have something blocking the movement of the material through the sinuses that are in the spleen. Okay, immune complexes could be an example, right? Next thing we want to look at is thrombocytopenia.
Hello. Hello friends, I am Dr. Pritesh Junagade, hematologist and oncologist practicing in Nashik and Mumbai. I have been trained in hematology and oncology for 7 years, while I stay in UK, London. Today I am here to tell you about thrombocytopenia, meaning low platelet count, which is very common in our society. There are 2 reasons why I am discussing or sharing my views about thrombocytopenia. Number 1, there are many misconceptions around low platelet count, and Many of the population, especially in our country, are unnecessarily worried about low platelet count. Number two, I also want to give a message that low platelet count can be a serious disorder as well. So you can't just neglect a low platelet count or thrombocytopenia. So let's see next 5 to 6 minutes how we can understand low platelets or thrombocytopenia and take steps to diagnose and treat this condition efficiently. What are platelets? Platelets as a type of red is a type of cell in our body, in our blood, which is formed in your bone marrow. They come up into your bloodstream, they stay alive for 7 days. They're tiny structures. Their function is to prevent bleeding or they promote clotting and the other way around. So if you have a small cut while shaving or a small injury, platelets are the structures which go to the site of injury and they help in forming a blood clot. So obviously, if your platelets are low, which is called thrombocytopenia in the medical terminology, you will be prone for easy bruising or easy bleeding. That's how many of the patients of thrombocytopenia or low platelets present to a doctor. How will you come to know that your platelets are low? Without doing a test, of course. Is number one, if you start getting bruises or blackish, bluish areas on your skin or tiny pinhead like red dots on your feet, or some patients have easy bruising, bleeding from the gums, bleeding from the nose. And these are the common presentations of low platelet count in a given patient. So what are the common causes? Why are the platelet count goes low in certain patients? Well, again, there are many causes. The commonest are any infection, especially any viral infection which you all get, can lead to a low platelet count. In many of these, 90% of these people, it is not low enough to cause any problems. But with the new advanced tests which are available in our society today, you easily diagnose low platelet count. This was not the case 20 years ago. People used to get viral infection 20 years ago. They also had low platelet, but we didn't have a machine to count them. Now we've got a machine, so we come to know how common this condition is. So 90% of patients who've got viral infections, sometime or the other, the platelets are low. In most of these patients, you don't need any special treatment for low platelet. In 10 to 20% of these patients, when the platelets are very, very low, you need to be admitted in the hospital. And in certain patients, we need to give platelets from outside, which is called platelet transfusion. So this is viral infection causing thrombocytopenia. Your doctor will easily come to know and can suggest you treatment for low platelet count for the same. The next common cause is drugs or any medications which you are taking for some other medical illness. Many drugs can lead to thrombocytopenia and this should be kept in mind. Young children given routine vaccinations can lead to thrombocytopenia or low platelet count. Again, poor diet, especially vitamin B12 deficiency, which is a source, which is an important source of vitamin or which is important for platelet production as well, can lead to low platelet count. Again, we should remember certain hematological diseases. There could be serious diseases like aplastic anemia, blood cancer, Hodgkin's lymphoma, non-Hodgkin's lymphoma, multiple myeloma. All these conditions can also cause low platelet count. There are certain other rare diseases in the bone marrow which can lead to low platelet count. Also, if you've got repeated infections, an organ in your body which is called spleen enlarges and your platelets might be destroyed in that organ, which is there in the left side of your tummy. That can also lead to thrombocytopenia. So these are the common causes of thrombocytopenia or low platelet count in our society today. Next few lines about the treatment. How do we treat patients? As I have earlier told you about viral infections, patients can be treated on the basis of their low platelet count. If it is very low, you need to be admitted. Only 10 to 20% of patients need to be admitted with low platelet count. The rest of the patients can be easily managed by an outpatient basis, meaning they need not be admitted. Few of the patients who have really bleeding from gums or nose, who bruising, we need to give platelets from outside, from a donor, from a blood bank. That is called platelet transfusion. Again, we need to do certain special tests, which is called the bone marrow test, to find out whether platelets are being formed in the bone marrow. If they are not formed, there are certain diseases, other diseases, serious diseases we need to treat. And we'll treat them accordingly and should be treated by a hematologist. Well, after all this, low platelet count is treatable today. You don't need to panic. Always when the platelet counts are low, you should ask the doctor why platelet count is low, and you should get a satisfactory answer from the same. Again, spread this message that low platelet count is common, but we don't need to worry, we don't need to be panicked just because of platelets are low. Thank you for patient hearing, and if you need any further information, please do visit our website, which is there on your screen now. Thank you.
IgG antibodies target heparin platelet factor 4 complex, typically causes a 50% drop in platelet count. Okay. Idiopathic thrombocytopenic purpura is a chronic form that has IgG autoantibodies that target platelet glycoproteins. Antibody-coated platelets are sequestered and removed from circulation. Basically, your own immune system destroys. The acute form of ITP, it often develops after a viral infection, is one of the most common childhood bleeding disorders. What do we see? We see petechia and purpura. We see progression to major hemorrhage. Remember the petechia are ruptured capillaries that you can see in the sclera of the eye and under the fingernails and under the skin. Purpura is basically internal bleeding. Okay. Thrombotic thrombocytopenic purpura, or TTP, is a thrombotic microangiopathy. The platelets aggregate and they form microthrombi and cause blockage of arterioles and capillaries. There's different types: chronic relapsing TTP and acute idiopathic TTP. Remember that the term idiopathic means cause unknown. Okay. Essential thrombocytopenia. Essential thrombocythemia or thrombocytosis is characterized by a platelet count over 400,000 per cubic millimeter. Okay, it's a myeloproliferative disorder of platelet precursor cells. Megakaryocytes of the bone marrow are produced in excess. Microvasculature thrombosis or hemorrhage will occur. Okay, now you might wonder, okay, you're making all these extra platelets. Why are you hemorrhaging? Okay, it's the same reason that you hemorrhage in DIVC. Okay, disseminated intravascular coagulation. You're titrating out your clotting factors in the plasma, and so when you have an actual injury, you're going to bleed, all right, excessively, because it's going to take longer for the fibrin clot to set up. Other changes in platelet function. Qualitative alterations demonstrate an increased bleeding time in the presence of a normal platelet count. When we see petechia, purpura, mucosal gingival bleeding, that's bleeding in the gums. Then disorders can either be inherited or you can acquire them, right? One example is vitamin K deficiency, which is critical for synthesis and regulation of prothrombin, the procoagulant factors, which are 7, 11, and 10, and proteins C and S, which are anticoagulants, right? Liver disease causes a broad range of hemostasis disorders, defects in coagulation, fibrinolysis, and platelet number and function, not to mention the fact that you have a drop in most clotting factors because they're manufactured by the liver, as well as a decrease in albumin production and a decrease in complement production, which makes you more likely to succumb to infection. Okay, let's take a look at DIVC.
Hey, this is Dr. K from my medical school. Today we're going to talk about DIC, otherwise known as disseminated intravascular coagulation. So let's first start off talking about what is DIC. DIC is a massive activation of your coagulation system, leading to multiple clot formations throughout the body. from macro to micro thrombi. At the same time, because your body is using up all these factors to create these clots, there are not enough clots to prevent your body from bleeding. But DIC is not only characterized by clot formation, but also by excessive bleeding. In patients who do have DIC, this is a red flag for a severe underlying disorder. DIC is never a primary diagnosis, but a secondary diagnosis. Before talking about the specifics of DIC, let's talk about coagulation. Coagulation is split up into primary hemostasis and secondary hemostasis. Primary hemostasis is when there's damage to tissue or blood vessels, and platelets stick to this damage, creating a primary clot. The clot is strengthened by secondary hemostasis, and this involves the intrinsic, the extrinsic, and the common pathway. We'll go to the specifics of each pathway, but I'll highlight some important points. First, the intrinsic pathway is monitored by PTT. Your extrinsic pathway is monitored by your PT lab. The common pathway is very important, and both the intrinsic and extrinsic feed into the common pathway. In the common pathway, prothrombin is converted to thrombin by activated factor 10A. Thrombin is an enzyme or a protease that cleaves fibrinogen in inactive form to fibrin. The fibrin is to attach to the primary clot and stabilize/strengthen that clot. In the conversion of fibrinogen to fibrin, unnecessary parts of the protein are cleaved off, and these are known as fibrinogen degradation products, which is something we can measure in your serum. Now that we know the basics of coagulation, let's look at the details of DIC. So first, we'll look at what are the causes of DIC. The causes of DIC are wide, and they include trauma, vascular aneurysm, sepsis and severe infection, severe liver failure, transplant rejection, placental abruption, preeclampsia, pancreatitis or other severe organ dysfunction, amniotic fluid embolism, ABO transfusion incompatibility. Last but not least, malignancy. Note, all these disorders have systemic involvement, meaning they affect more than one organ. And that's probably the reason why they're associated with DIC. Now, how do you diagnose DIC? No single test diagnoses DIC. Really, you need to look at the entire clinical picture to lead you to diagnosis of DIC. That includes the history, the physical, the labs. Next, we look at labs that are commonly associated with DIC. And then we will take a look at a scoring system that can help aid us in our diagnosis. So first, let's take a look at thrombocytopenia. Thrombocytopenia means a low platelet count. The reason thrombocytopenia develops in DIC is that because of the activation of the clotting system, primary hemostasis is activated, and those clots start to stick everywhere they can to form these primary clots, and thus they're consumed. No, thrombocytopenia is sensitive for DIC, but it's not specific because a lot of things can cause thrombocytopenia. Next, we'll look at fibrinogen degradation products and D-dimer. Fibrinogen degradation products are a result of the clotting system activating and causing the cleavage of fibrinogen to fibrin, creating FDP, or fibrinogen degradation products. The reason we measure fibrinogen degradation products in DIC is that if the body is activating the clotting system at a very rapid rate, fibrinogen becomes converted to fibrin very quickly, producing a lot of fibrinogen degradation products. So if the FDPs are high, we can infer that the clotting system is undergoing a massive activation. Now, fibrinogen degradation products are hepatically and renally metabolized into the liver and through the kidneys. Because of this, if the patient has liver or kidney dysfunction, the fibrinogen degradation products may be falsely elevated. So that's something to keep in mind when interpreting this test during a patient who you think has DIC. Now we will look at the coagulation labs that we commonly get on patients. So PT and PTT. PTT measures the intrinsic pathway, and PT measures your extrinsic pathway. In about 50 to 60% of patients who have DIC, you will have a prolonged PT and PTT. Thus, you can actually use the PT and PTT to monitor DIC patients because they measure the pathways that involve the factors that are consumed in DIC. Another lab we commonly get is fibrinogen. Fibrinogen is classically used to diagnose and monitor DIC. However, you must realize fibrinogen in most cases may not be very helpful. And the reason why is fibrinogen has a very low sensitivity for diagnosis of DIC at about 28%. Why is it so insensitive? Well, fibrinogen is an acute phase reactant, meaning when the body is stressed or sick, the body will produce fibrinogen. So the fibrinogen level may be falsely normal, though the body is rapidly consuming fibrinogen. Hypofibrinogenemia is rarely detected in DIC. Really, it's only seen in the most severe cases. Let's talk about schistocytes, which are fragmented RBC. Fragmented RBCs or schistocytes are reported in patients with DIC, but usually they are only about 10% at the most of red blood cells. Sometimes they can be. It's not a sensitive or specific finding to DIC because schistocytes are associated with many other disorders, including mechanical heart valves, vasculitides. You really, when you see schistocytes, consider other things that could be causing it, such as thrombotic thrombocytopenia purpura or other microangiopathies. Now, let's talk about antithrombin and protein C. Antithrombin and protein C are involved in coagulation cascade and are often reduced in DIC. Though they do not diagnose DIC, they have been shown to have a prognostic significance. The scoring system we use in DIC is part of the International Society for Thrombosis and Hemostasis DIC scoring system. It's a fairly simple system, a 5-step diagnostic algorithm. The prerequisite is that the patient must have an underlying disorder known to be associated with DIC. It is 91% sensitivity and 97% specificity, making the scoring system very good in diagnosing patients who have DIC. So let's go over the system for DIC. So first off, you want to know, does this patient have an underlying disorder known to be associated with overt DIC? If the answer is a resounding no, then you cannot use the scoring system. However, if the patient does have an underlying disorder that's associated with DIC, you need to obtain coagulation tests. So your PT, platelet count, fibrinogen, and a fibrin-related marker such as FDPs or D-dimer. So now we understand how to interpret the labs that we obtained. So we use a scoring system based on these labs. So for your PT, if your PT is less than 3 seconds, you get 0 points. Greater than 3 but less than 6 seconds, you get 1 point. And then greater than or equal to 6 seconds, you get 2 points. Now let's move to the platelet count. So for patients who have platelets of greater than 100,000, you get 0 points. For patients who have platelets between 50 to less than or equal to 100,000, you get 1 point. And less than 50,000, you get 2 points. Next, we'll talk about fibrinogen levels. So for a fibrinogen level greater than 1 gram per liter, you get 0. And for a level less than 1 gram per liter, you get 1 point. Now let's move on to fibrin markers, so D-dimer or FDPs. If there's no increase, you get 0 points. There's a moderate increase, you get 2 points, and a strong increase, you get 3 points. Now let's calculate the score. If you get a score that's greater than or equal to 5, that's compatible with overt DIC. For patients less than 5, This is suggestive of a non-overt DIC. So greater than or equal to 5, you have a definite diagnosis. If you have greater than or equal to 5, you need to calculate the score every day to monitor the patient and how they are doing with the DIC, whether or not they're improving or they're getting worse. But less than 5, we have a high clinical suspicion. Recalculate in 1 to 2 days and see where the score has trended. All right, we've gone over diagnosis. Let's talk about treatment for DIC. So for treatment, you always want to treat the underlying disorder for DIC because DIC is a secondary diagnosis. But if the patient is actively bleeding or needs an invasive procedure and the platelets are less than 50,000, I would go ahead and transfuse them with platelets. Now, in non-bleeding patients, our general goal is greater than 10,000 platelets. Just because less than 10,000, your risk of spontaneous bleeding is so high. Now, for patients with severe hypofibrinogenemia, like less than 1 gram per liter, even though they have gotten FFP, then at that point, you can consider cryoprecipitate. But realize there's no data to suggest that this improves outcomes in DIC patients. Because DIC involves the creation of clots, there's always been this question whether heparin should be used in DIC. Now, heparin does inhibit the activation of the coagulation part of DIC. But realize there's no randomized trial that's demonstrated heparin use in patients with DIC had improved outcomes. So generally, we stick with the rule that if the patient is critically ill, they have suspected DIC, but there's absolutely no evidence or risk of bleeding at that point, then you can consider prophylaxis with heparin or low molecular weight heparin at prophylactic dosages to prevent clot formation. But this is really the minority of patients you probably be using this in. All right, we've gone over CIC, the diagnosis, DIC. If you like this video, give it a like. If you have any comments or any ideas for future videos, please comment down below. And definitely subscribe to I Am Medical School. It's time.
Other thromboembolytic disorders, Virchow triad. Okay, Virchow triad postulates the presence of 3 factors that predispose a person to develop vascular thrombosis. They include hypercoagulability of the blood, alteration of blood flow in the vessels, and vessel wall injury and endothelial damage. Okay. Hereditary thrombophilias, most of which are autosomal dominants, because of what involves structural proteins, increase the risk of thrombosis. More than 100 different known mutations exist, have been characterized. Acquired hypocoagulability include deficiencies in proteins S, C, and free, and can also be characterized as antiphospholipid syndrome. So what are these? They're either acquired or inherited. Actual thrombus occurs due to the interplay of both genetic and environmental factors and follows a multiple hit hypothesis, explaining the inter-individual differences observed in patients with inherited mutation. Genetic factors can now be identified in up to 30% of the patients with VTE and are mainly attributable to factor 5, okay, Leiden and prothrombin G2021A mutations. These 2 thrombophilias implicate a weak thrombotic risk. Other inherited thrombophilias are rare, such as antithrombin 3, protein C, and protein S deficiency, which are about 1% of the general population, but they pose a higher risk for thrombosis. Acquired factors also influence coagulation cascades and include surgery, pregnancy, hormone replacement therapy, contraception, malignancy, inflammation, infection, and heparin-induced thrombocytopenia. Remember that activated protein C is the proteolytic component of the complex, and protein S serves as the activated protein C binding protein that's critical for the assembly of the anticoagulant complex on cell surfaces. The anticoagulant activity is expressed through the selective inactivation of factors 5A and 8A. Okay. All right. Let's take a little break. I'm going to pop open all the quizzes that you've got attempted.
Okay, I know we're over time. We are done for today. I'm going to see everybody tomorrow. But remember that it's going to be online, right? You don't have to come in. So it'll be another Zoom session. And I will have some review for you at that time. Appreciate y'all being in here today.